have no financial disclosures or conflicts of interest with the presented material in this presentation. So here's a quick overview of what we're going to be discussing today. First, I'm just going to outline the role of neuropsychology in general. And then we're going to walk through how concussion and mild traumatic brain injury are currently defined, including how different organizations approach these criteria. I'm also going to dig into the controversies around the term post-concussion syndrome, and why it's problematic and what terminology may be more clinically accurate. I'm also going to highlight some of the key risk factors that predict prolonged recovery, from pre-morbid and injury-related variables to post-injury psychosocial influences. And then finally, we'll explore how beliefs and expectations can shape symptom persistence for better or worse, and wrap up with evidence-based strategies to guide treatment and improve outcomes. So I think it's really important that individuals in neuroscience, neurology providers understand the role of neuropsychology and what I do. I want to discuss that what clinical neuropsychologists are asked to do is to evaluate brain behavior relationships. We use standardized performance-based testing, so that's psychometric testing, to assess cognitive domains like attention, processing speed, language, visual-based skills, memory, executive functions. These evaluations are often used to clarify diagnosis. A lot of the times my referrals are, hey, does this person have just normal cognitive aging, or is this something neurodegenerative? I also help guide treatment planning. I'm asked a lot of times from our PM&R folks to help with decisions to return to work, decisions to return to school, and accommodations, as well as access to other services to support recovery. And we also want to help patients and providers understand the impact of their neurologic conditions. We also work in many collaborative care settings and models. I work on multidisciplinary presurgical epilepsy clinic as well as the DBS presurgical clinic. You'll also see neuropsychologists in rehab settings work with in a multidisciplinary concussion or brain injury models. So we do provide a lot of different roles, and I think our roles as neuropsychologists have certainly shifted over the years because we also provide a lot of education and consultation services as well, because I think we do have this very niche specialty, and we really do understand the role of brain behavior, psychological components, and kind of that biopsychosocial interference. I'll also point out that neuropsychology is distinct from neuropsychiatry. I see people all the time request for a neuropsychiatric evaluation. We do accept it, but it's not correct. I know what you mean. We are a neuropsychology. So while both neuropsychiatry and neuropsychology deal with the interface of brain and behavior, neuropsychiatry is a medical specialty rooted in psychiatry, and it often involves medication management in neurologic populations. So let's start with some definitions and context. So this is the classification system that many of us probably are familiar with, used by the Defense and Veterans Brain Injury Center. It's been echoed in various guidelines. TBI severity is traditionally classified based on clinical indicators such as loss of consciousness, post-traumatic amnesia, changes in mental status, GCS. In mild TBI or concussion, we typically see brief or no loss of consciousness, GCS between 13 to 15, brief post-traumatic amnesia, and normal structural neuroimaging. So for this talk, I will be talking more so about uncomplicated mild TBI or uncomplicated concussion, so where there are no structural neuroimaging abnormalities identified. So one of the ongoing challenges in both clinical and research settings is that there isn't a single universally accepted definition of concussion or MTBI. Multiple professional organizations have put forth their own criteria, including the CDC, Mayo Clinic, the American Congress of Rehab Medicine, as well as the Department of Defense and VA. While there's overlap, each brings subtle but meaningful differences, and there is that lack of standardization. The variability in terminology and criteria can certainly complicate diagnosis and research comparisons and even treatment recommendations. So here we have the updated 2023 American Congress of Rehab Medicine criteria for mild traumatic brain injury. This was a very long anticipated revision of their 1993 criteria, so it's been about 30 years. One major update in this new criteria explicitly allows us to incorporate a broader range of evidence that can be used to establish a diagnosis of concussion or MTBI, including observed signs, patient-reported symptoms within the first 72 hours, clinical exam and laboratory findings, as well as neuroimaging when available. Importantly, this new criteria update adds more nuance around imaging. While in the past, concussion and MTBI was historically defined by the absence of abnormalities on standard clinical imaging, we now recognize that there are some advanced imaging models that can show subtle findings that are still consistent with a mild injury. This also this criteria also puts more emphasis on clinical judgment, recognizing that not all patients will present in a textbook fashion, and that's for sure with our concussion patients. It encourages a more functional approach to diagnosis that incorporates patient-reported data and context. So in a clinical practice, this means we need to look just beyond the emergency room documentation, and we need to ask about the injury mechanism, the early symptoms, how the patient functioned immediately afterward. I'll also note that in this criteria, they did comment on using terminology of concussion and MTBI interchangeably, which has always been, it's been a big debate because a lot of people have used concussion as a milder version of severity of MTBI. They also added a specifier of suspected when evidence is incomplete, but injury is likely. And I also just want to shout out that the first two authors on this paper were neuropsychologists, as well as 6 other authors on this paper. So it just shows kind of the role of neuropsychology within this specific patient population. Now here we look at the more specific core clinical signs, acute symptoms, and laboratory findings that can support a diagnosis of MTBI in the new criteria put forth by the ACRM. Clinical signs are these observed or elicited findings, such as difficulty following multi-step commands, agitated behavior, slowness to respond to questions and instructions. While acute symptoms onset within the first 72 hours after the head injury are subjective feelings of change in health, such as difficulty concentrating, feeling confused, balance problems, sensitivity to noise, those things. It's important to recognize that those acute symptoms are not specific to concussion, but in the right clinical context, they do help to establish the diagnosis. So in the ACRM criteria, you can have one clinical sign to meet criteria for concussion, or you can have 2 acute symptoms along with one lab finding or exam finding, and that is biomarkers or cognitive impairment found on certain types of cognitive exams or oculomotor exams that can be done in clinic. So when it comes to diagnosing concussion or MTBI, it's important to remember that this, of course, is a clinical diagnosis, and there's no single definitive test. But I'm going to briefly touch on several tools that can support this process. Now, I know that a lot of maybe individuals in here are more neurology focused and we're not in the emergency department. We're maybe not the first point of contact for these patients or the primary care provider. But I think it's important to be aware of like what tools that there are to use, such as the acute concussion evaluation, as well as the sports concussion assessment tool. These are structured tools often used in acute or the sideline settings. There's the vestibular ocular motor screening for concussion as well, particularly when patients have dizziness, visual disturbance, or balance complaints. And imaging decisions are guided by clinical decision rules. I'm sure people are aware of the Canadian CT head rule to help determine when a CT scan is necessary to rule out a more serious injury. Um, I also wanted to briefly highlight the use of blood-based biomarkers, which is mentioned as a laboratory finding in the updated ACRM criteria to aid in the diagnosis of concussion or MTBI. Some of the biomarkers under study include GFAP, CUHL1, NFL, TAW, each of which reflects different types of neuronal or glial injury. In research settings, these markers have shown promise in identifying subtle brain injury, even when that structural imaging is negative. But these biomarkers are not ready for routine clinical use in our outpatient settings. There's still issues with timing, as well as um, variability between individuals and interpretation in the context of comorbid conditions. So while I think it's a really fascinating area of development, for now, our primary diagnostic tools are going to remain the clinical signs, reported symptoms, that clinical history and exam, and the judicious use of imaging and those validated screening measures. I also will see in clinic a lot of patients come in with diffusion tensor imaging, or DTI, imaging done. And that's another area that's drawn a lot of attention in concussion research. DTI is a form of advanced MRI that looks at the microstructural integrity of white matter, particularly how the white matter diffuses along the axonal tracts. It's been used to detect subtle changes in brain functioning after concussion that might not show up on that conventional imaging. However, the clinical utility of DTI is still very limited. Um, the findings are inconsistent. Some studies show variable directions of change, and the results often depend on the timing of the imaging and the brain regions that are actually scanned. It's also highly sensitive to artifact, and there is no widely accepted normative database for comparison. Um, and also, I think that this is a take-home message, is that DTI changes are not specific to concussion. You can see that in demyelination, edema, axonal loss, inflammation. And Wild and colleagues in 2019 um, uh, did a study and said that concussion and trauma controls differ from uninjured controls on DTI, but not from each other. And I think that really muddies interpretation. So while it may be a valuable research tool, I think that it's not a reliable or prognostic tool for individual patients in our clinic. And I really caution people over interpreting this when maybe a patient comes into clinic with these from a outside provider, these findings. So I'm going to have a case study throughout, and we're going to follow her. This is actually a patient I saw in 2018. I was on postdoc at the University of Virginia. And she was a 29-year-old white female with 16 years of education. She had actually sustained a concussion in a motor vehicle collision 4 years prior to me seeing her. The motor vehicle collision, the parameters around that, she was the restrained driver of a sedan. She was stopped at a stoplight, at a complete stop, and she was rear-ended by a vehicle traveling at approximately 45 miles per hour. There was airbag deployment. She reported having a brief loss of consciousness she wasn't really sure, but she thought it was maybe less than a minute. She reported a post-traumatic amnesia of about 10 minutes. She was actually ambulanced to a local emergency department due to the immediate symptoms of kind of lightheadedness, stiffness of neck, and headache. Her GCS was 15 upon arrival, and she was released the same day, but she said she was given no information about concussion, if she had a concussion, and so she was just really confused about that. but we're going to follow her case throughout my presentation. So let's talk about recovery, which for most patients with concussion or MTBI is favorable. So the majority of individuals, particularly athletes, recover within 7 to 10 days, and most non-sport related concussions resolve within 30 days. There is a little less than a third of individuals that will report symptoms after that last longer than the month. And it's that group that really requires closer follow-up and a more nuanced multidisciplinary approach. So there's a common concern among patients and sometimes even providers that concussion can cause long-term cognitive problems or damage. But the data across 6 very well done meta-analyses reveals a consistent finding of no evidence of lasting neurocognitive deficits in individuals following concussion. Now, the early phase, meaning within days or a few weeks post-injury, is where we see transient cognitive inefficiencies, slower processing speed, attention problems, mild memory issues. But these typically resolve with time. So when someone presents months or even years after a concussion, still reporting significant cognitive problems, we have to broaden our lens and consider other contributing factors. So this is a very messy diagram, but I think it really shows how these concussion patients can be. They're not always the most straightforward and can be somewhat difficult. Recovery after concussion isn't just about the injury itself, okay? It's shaped by a number of pre-injury, injury-related, and post-injury factors. This biopsychosocial model is essential for understanding why some patients bounce back quickly from a concussion while others develop persisting symptoms. We're going to unpack each of these in more detail, but the key point is that recovery isn't just about what happened on the field or at the time of injury. It's about what happened before, what happens next, both psychologically and environmentally. So let's break down the pre-injury factors that have been linked to prolonged recovery. From the literature, there is a lot of support that female sex is consistently associated with a higher risk of persisting symptoms. The reasons for this may be multifactorial, including hormone differences, injury biomechanisms, as well as even differences in symptom reporting. A history of ADHD or learning disorders is another important risk factor, particularly when patients already struggle with attention or executive functioning, making it harder to tolerate those transient inefficiencies post-injury. Prior concussions also increase vulnerability, especially if they occurred close together or they hadn't fully recovered from their head injury before. Mental health history, including depression, anxiety, panic attacks, is a significant predictor for persisting symptoms. These symptoms can amplify, or these conditions can amplify symptom awareness, contribute to catastrophizing, and complicate recovery. Other red factors include poor coping skills, limited social support, somatization orientation, also sleep disturbance. Even before the injury, if this is happening, it is a powerful driver of both cognitive complaints and mood instability. So if someone wasn't sleeping well before, they're going to have a hard time recovering. Now we're going to look specifically at the injury itself and things that would influence recovery. One important variable is the context of the injury, whether it occurred during sports, a motor vehicle collision, military duty, a fall. These situations come with very different, each of them, with very different emotional and physical demands and dynamics. And that can affect both symptom onset as well as patient expectations. Um, Loss of consciousness isn't required for diagnosis, but when it occurs, it's often interpreted by patients and providers as a sign of severity, which can shape symptom perception as well as concern. Early onset pain, particularly headaches, within the first 24 hours has been associated with worse outcomes. We know that whiplash and cervical strain are often overlooked, but these can contribute significantly to dizziness, headache, and poor sleep. all of which would complicate recovery. And finally, the number of symptoms reported early on, often referred to as symptom burden, is one of the strongest predictors of who will go on to develop persisting symptoms. The more intense the initial presentation, the greater the likelihood of severity. Now, post-injury factors are often the most powerful and the most modifiable. So let's start with secondary gain, such as litigation or disability compensation. The presence of external incentives can unconsciously reinforce symptoms or delay return to function. We'll see emotional distress, including trauma responses, anxiety, depression, again, is a huge contributor after the concussion. Um, we also see that not returning to work or meaningful activities or delaying that return can actually prolong symptoms. Activity restriction can lead to deconditioning, isolation, as well as a loss of confidence, all of which contributed to persistent symptoms. And lastly, beliefs, expectations, and attributions can prolong recovery, which we will get to in the next slide. So this is a very busy slide, but this is a very important slide in my opinion. And this really gets the heart of how expectations shape outcomes in concussion. The concept of the nocebo effect, essentially the opposite of the placebo effect, is highly relevant in concussion care. So the nocebo effect refers to new or worsening symptoms that develop in response to negative health-related information, beliefs, or expectations. When patients are told or believe that their brain is permanently damaged or the recovery will take years, that expectation alone can contribute to prolonged symptoms. I also want to highlight that language matters that you use in the clinic. Even well-intentioned providers can inadvertently reinforce fear through overly cautious or alarming phrasing. Terms like post-concussion syndrome or permanent damage can stick with patients and drive fear avoidance. Research has suggested that even referring to a head injury, a concussion MTBI, as a traumatic brain injury rather than a concussion can actually worsen clinical symptoms. We also see the role of misattribution in concussion patients, where normal fluctuations in mood, cognition, or fatigue are falsely linked to the concussion. This is sometimes referred to as the good old days bias, where patients idealize their pre-injury functioning and interpret any current difficulty as abnormal. I also want to touch on fear avoidance. This is where symptoms are mistakenly interpreted as a sign of serious injury and they catastrophize, over which a patient has no control, and then the patient then avoids activities that they conclude are worsening their condition, when actually avoidance of the activity is driving the symptoms. And I see that a lot in my clinic with cognophobia. People are afraid to engage in more difficult thinking skill tasks because they believe it brings on their headaches, and things of that nature. And lastly, there's diagnosis threat, and iatrogenic effects, and they are very real. The more attention and scrutiny a patient gives to their symptoms and the more medicalization that occurs, the more likely they are to feel impaired, even in the absence of objective findings. So I'm going to get back to that case of the female that I saw in clinic in 4 years after her concussion. And so after she had had that concussion, over the course of the following week, she experienced increased headaches, nausea, sensitivity to light, dizziness, hip and back pain, and difficulties with concentration and focus. She stated that she actually returned to a local emergency department the next week to be reevaluated for her persisting symptoms. Because remember, she had never been told if she had had a concussion or not in her initial evaluation in the emergency department. She had another head CT, which again was negative. And she was actually in college at the time of her concussion. And given her persisting symptoms, she took medical leave for the remainder of the semester instead of getting accommodations. She ended up returning to school for the following semester. However, her medical records noted that in class, she was experiencing increased migraine headaches, light sensitivity, and difficulty with concentration and focus. And given these symptoms, it was recommended that she take medical leave for another semester to allow for further recovery. Now, when I saw her in clinic, just some other medical history for her, she had no prior mental health concerns and no substance use history. She did have migraine headaches pre-existing the concussion, as well as some insomnia. And she did have an ADHD diagnosis that had been provided at the age of 8. She was a full-time student as well as employed full-time as a secretary at the time of the motor vehicle collision, so she certainly had a full plate. So now let's move forward with the controversy and limitations of the term post-concussion syndrome. This is a term that I don't use. So I'm going to read off some symptoms. Okay, difficulty concentrating, headache, irritability, fatigue, memory difficulties, stress intolerance. How many of you have experienced at least one of these, even just in the past month? I mean, I can say I have. Right. Many of these symptoms are incredibly common, okay? But when they start or persist after a concussion, we begin thinking about something different, post-concussion syndrome. So, PCS or post-concussion syndrome is a term that's been widely used, but increasingly questioned. Historically, it's been used to describe lingering cognitive, physical, and emotional symptoms after a concussion, things like difficulty concentrating, headache, irritability, so on. The term PCS has certainly lost meaning over time because of misunderstanding by patients and providers, overuse, or inappropriate use applied at incorrect times, and certainly misrepresentation in the media. PCS has become a generic diagnosis that's been applied ranging from the day of the injury. I have seen it in the emergency department. They will write, "This is PCS," or years later, 8 years later, 10 years later, um, when new or unexplained symptoms arise. This brings us to an important question. So, if PCS is so widely used, why is it being questioned? Let's take a look at some of the major shortcomings of the term and what makes it such a controversial diagnosis. First, I want to state that the literature is pretty clear that PCS as a diagnostic category lacks specificity. Studies have shown that PCS type symptoms are just as prevalent in people with no brain injury, including those with depression, chronic pain, ADHD, sleep disturbance, healthy controls, people that work at UofL. So if we're seeing the same symptom profile across these unrelated groups, it suggests the cluster isn't unique to concussion, and that's a big problem when it comes to guiding treatment. There are also problems with the term syndrome itself. By definition, a syndrome is a fixed set of symptoms with a common underlying cause. The appearance of one symptom in a syndrome means it is highly likely that the other symptoms will appear too. But in the case of PCS, the list of symptoms and their possible combinations are so highly variable, and syndrome is imprecise terminology. The term post-concussion suggests that any symptom occurring after the injury must be due to the concussion itself, when in reality, many symptoms may be pre-existing, co-occurring, and even new onset and unrelated. This framing of using the term post-concussion can easily lead to misattribution and chronicity. So, a number of experts in the field, including a prior supervisor of mine, have proposed retiring the term PCS and using something more precise. And I particularly, you'll see like persisting symptoms or persisting post concussion symptoms. I prefer the terminology persisting symptoms after a concussion or PSAC. This was first proposed in 2019 by a work group at the International Congress of Athlete Brain Health of the Athlete Brain Health Foundation. And really, what they're wanting to propose was this new terminology to shift the focus on active rehabilitation with the goal of recovery and improve quality of life, regardless of symptom duration. The language intentionally is more descriptive and less pathologizing, noting symptoms that are worsening or not improving after at least 1 month. It also acknowledges that symptoms may persist, but they may result from pre-injury, co-occurring or resulting factors, not necessarily the concussion itself. It also removes the implication that there's a defined unitary syndrome. Instead, it invites us to take a case by case approach, identifying what's really driving impairment and how we can intervene. So let's get to when I first met the patient in clinic. So I gave you a little bit about her background. The first thing I want to note is that she was referred by a neurologist to assess her cognitive and emotional functioning, secondary to that concussion that had happened 4 years prior. Um, when I met with the patient, it was very evident that she had identified with having post concussion syndrome. You'll see, like, I have a brain injury, I have post concussion syndrome, and was very much so a fixed identity with that, which can be quite difficult to work with. And she did state that she had permanent brain damage. Some of the symptoms that she had reported at the time when I saw her was this abrupt onset of cognitive changes following the motor vehicle collision, which fluctuates or are variable daily. She reported changes in focus, multitasking, working memory, being able to hold information in mind and manipulate it for a period of time. Speed of thinking, which was not slowed, but it was actually increased fast, which is kind of, interesting. Word finding, difficulties, as well as short-term memory problems, particularly forgetting recent conversations. She had no pre-existing mental health history, but at the time that I saw her, she said, "Oh my gosh," she admitted to having anxiety and depression after the head injury. She had had a lot of stress in the 4 years since that. There was ongoing litigation around the motor vehicle collision. It had not obviously been finalized, and that's typical. She had been wanting to conceive a child, and that had not been going well. She had actually lost her mom a year after the motor vehicle collision, and that had been kind of abrupt and unexpected. She was then also now put into a mother role. She was kind of providing the emotional support for the family, and she reported having poor social support, aside from her husband. Now, she was reporting headaches still. Now, she had pre-existing migraines, but at this time, she was having 1 to 2 headaches a week, and she rated those on a 6 on a 1 to 10 pain scale. She was reporting some vestibular issues, particularly dizziness, when staring at a computer screen for an extended period of time. And her sleep had been uh, she was reporting really poor quality of sleep. She was getting 7 hours of sleep, but she was often waking up feeling really unrested, and she was reporting some hypersomnolence throughout the day. And I did the stopping with her, and she got a score of 4. So let's get back to now that we've gone through understanding a little bit more about our concussion patients and expected recovery. And now, how do we treat them? And that's a lot of the questions that I get. I think treatment first should begin with a comprehensive evaluation. And I think we each have our own, obviously, niche specialties. So whether that's a clinical interview, physical exam, neurologic exam, of course, history taking, there's no one size fits all approach to these patients. Sorry. That's just not how it works with them. For some patients, the primary driver is mood disturbance, while from others, it might be sleep dysfunction, vestibular issues, misattributed physical symptoms. The key is to assess what's actually contributing to the symptoms they're experiencing in order to come up with an individualized treatment plan. And like highly encourage people to refer to specialists and multidisciplinary concussion clinics. Um, I worked on a multidisciplinary concussion clinic, and it really did help healthcare, reducing healthcare utilization for these patients because they can utilize a lot of healthcare and they have a lot of needs. So, in the following slides, we're going to walk through evidence based treatment strategies for some persisting symptoms of a concussion. I'm going to target sleep, mood, and cognition. But given time restraints, I'm not going to be able to discuss all of these in great detail. But I have provided slides in my deck regarding best practices for the other treatments, management for headache, vestibular ocular motor issues, fatigue. And I'm happy to share these slides with anyone that emails me after this for this, just to use for clinic. But before we go into specific symptom management, I want to discuss how we deal with the nocebo effect. So we already discussed that nocebo effect is where negative expectations lead to worse symptoms. And I really want to drive home that the most powerful therapeutic tool that any of us have in here is really education and communication with these patients, particularly like active listening. I think it's really important to we need to educate patients early and consistently. Actively listening to patients' concerns allows us to identify and correct false beliefs, reinforce the expectation of recovery, and framing symptoms as common and transient, not signs of permanent damage. Ask open-ended questions to surface patients' fears, such as what concerns you the most about your symptoms. This not only builds trust, but it gives you a chance to directly counter fear-based thinking. We should also be mindful of the terminology we use, like I said earlier. For example, the difference between saying post-concussion syndrome versus you're experiencing symptoms that are common after a concussion and fully treatable can shape how the patient understands their experience. I often, if you've ever read a report of mine, and it's a concussion patient, I often avoid using the terminology TBI in my reports and often will refer to the head injury as a mild head injury or concussion, as I know that TBI sounds really scary to people. It does. And I know that that can also make outcomes worse when you're instilling that fear. I also recommend patients, providers to kind of avoid exhaustive symptom checklists unless clinically necessary. I instead encourage patients to report bothersome symptoms in their own words because this reduces symptom priming. So they're often super hypervigilant and really focuses more on recovery. And lastly, I think the big thing is that if any of you all have worked with concussion, they are one of the more difficult patient populations that we can work with. Um, and I always encourage people to respect the injury itself. But probably the best thing you can do is meet that patient with compassion and a lot of perspective taking. That's what I do in clinic a lot is, man, I can't imagine this patient has maybe not been provided the best education. They've been pushed around to a lot of providers. Man, they're still having headaches. They haven't been able to work. There's financial strain, X, Y, and Z. So I think that being able to meet your patients with that compassion can make your life easier and also maybe see it from their lens, how they've been experienced the last year or 6 months or 4 years, whatever it is since their concussion. And hopefully that can foster the relationship that in the end will help the patient adhere to the treatment recommendations. So, sleep problems are incredibly common after concussion, but they're also one of the most powerful drivers of prolonged symptoms. Poor sleep amplifies fatigue, pain, mood symptoms, and cognitive inefficiencies. So it's critical to screen for sleep disturbance routinely, asking about sleep onset, duration, quality, and wake time consistency. If sleep disruption is significant or predates the injury, it's worth considering maybe a primary sleep disorder like obstructive sleep apnea or insomnia. Treatment often starts with education, explaining how concussion can disrupt sleep wake cycles and reinforce the importance of consistent routines. Um, I often sometimes will recommend cognitive behavioral therapy for insomnia. That is kind of the gold standard for that condition, as it targets unhelpful sleep beliefs, reinforces sleep hygiene, and uses behavioral strategies like stimulus control and sleep restriction to retrain the brain. Prescribing exercise can also be helpful. And if necessary, short term sleep aids can be used, but we want to avoid long term use of sedating medications as this can often mask or other issues or delay recovery. And here are some, we're not going to get into these, but treatment approaches for post traumatic headache. You all are probably better at that than me. Pain, um, vestibular ocular motor symptoms, particularly noise, light, and other sensory sensitivities. A lot of them have phonophobia, vision therapy, vestibular therapy, tinnitus, things like that. Fatigue, very much so. What is the underlying etiology? Is figuring out what is driving that. Can be a lot of things. But my bread and butter is cognitive symptoms. So, cognitive complaints are some of the most common persisting symptoms after concussion. Um, Things like forgetfulness, slowed thinking, distractibility, word finding problems. But in most cases, they aren't signs of structural brain damage. They're functional cognitive symptoms or problems influenced by mood, fatigue, sleep, and largely attentional focus on the symptoms. They're often so focused on all their symptoms that it's taking away their attention from the task at hand. Um, in my role, the first step is psychoeducation, helping patients understand that these changes are real, but also transient and reversible. Setting expectations around recovery is often more effective than any specific cognitive exercise. We can also focus on compensatory strategies. This can help patients regain confidence while symptoms are still present. I also will encourage a graded return to cognitively demanding activities such as work or school tasks, balanced with rest. The goal isn't to avoid challenges, but to build the tolerance without pushing to the point of symptom exacerbation. And finally, always assessing for those contributing factors like headaches, medication side effects, mood symptoms, or sleep disruption, all of which can mimic or worsen cognitive inefficiencies. Treating those drivers often leads to the biggest cognitive gains. Oh, I'm sorry, I did not. Um, so I often get asked, is a comprehensive neuropsychological examination warranted for patients with reports of persisting cognitive symptoms outside the post-acute phase? So, in 2020, the American Congress of Rehab Medicine published practice guidelines regarding the management of concussion and MTBI. In Table 1 here, this is a review of recommendations by multiple guidelines or statements over the years that were summarized, including the Ontario Neurotrauma Foundation, the CDC, VA, DOD, as well as the consensus statement on concussion in sports. So you'll see with the star here, the recommendation for neuropsychological assessment to investigate persisting cognitive symptoms and concussion after that 30-day mark was generally a weak recommendation or not specifically recommended for most of these statements. But actually, since these guidelines were published, the Ontario Neurotrauma Foundation have since updated their guidelines in 2023, and it's essentially now a weaker recommendation aligning with other guidelines. And with the Ontario Neurotrauma Foundation, they generally they have their own kind of recommendations for when maybe a neuropsychological assessment is warranted. And that is where there is functionally limiting cognitive impairment, comorbidities potentially impacting cognition have been optimally managed. So, mood, sleep, pain. There's no ongoing cognitive symptom improvement, and those cognitive symptoms are prolonged. So, the support for a comprehensive neuropsychological assessment for concussion is often not routinely recommended, but it may be useful on a case by case basis. And in our clinic, and really even in my early career, I've seen the shift where doing comprehensive evaluations and patients in our office for 3 or 4 hours to going to a model where we're doing more screenings, like an hour of testing, to consultations and just essentially providing psychoeducation, talking to the patient for an hour or two about the symptoms and coming up with a treatment plan. And so I've kind of been in every model. Here we are either doing screenings for the patient or we do a consultation. There are obviously other patients that we do think need comprehensive evaluations because we think maybe the concussion is a red herring. And I've had many patients that actually had an underlying neurodegenerative disease or other things. So I think it certainly, again, is a very individualized case by case basis when we're doing that here. Now, let's go back to the patient. So in 2018, I was on postdoc, and so we were doing comprehensive evaluations that actually shifted. At the end of that, we moved to more of a consultation slash screening model. Um, but if you remember, she reported diffuse cognitive problems that were really impacting her functioning. And as you'll see, this is actually, if you've read any of our reports, this is the table that we do provide. So I'm just like priming you to this. And this is her results. Okay, she had 2 pages because it was that long, unfortunately. And you'll see here that she has average intelligence. So that's kind of the top, that general ability level. So for someone of average intelligence, we would expect that, low average, average, and above performances are considered within expectations. So green is good. That's what I like to tell my patients. And what I'm seeing here is that attention looks great, language skills, visual spatial skills, um, her verbal learning and memory, her uh, visual-based skills. All of these are excellent. And I want you to know that, and remember that subjective cognitive complaints are often very discrepant from what we see on objective testing. So quickly, let's get through mood symptoms. So mood symptoms are extremely common after concussion, not just as a result of the injury itself, but because of pain, sleep, stress, fear about recovery, and disruption to normal routines. That's a big thing. People not being able to return to work, drive, getting clearance, financial strain, litigation, things like that. I think the first step in managing mood symptoms, again, is psychoeducation, normalizing those emotional changes. We also want to screen proactively. I really encourage, if you're seeing a concussion patient in clinic, that you are giving the PHQ-9, the GAD. I'm not sure if you all access the post-traumatic checklist for the DSM-5, but the PCL-5 is, if you think that there are trauma symptoms, that's a really good measure to use. I really highly encourage you to use those. I think that's a really great tool to have. Because I think that can really help clarify diagnosis or just even what referrals need to be considered. Referring to mental health services are obviously important. I think that SSRIs are often the first line when medication is needed, but I really think that should ideally be combined with a psychotherapy like cognitive behavioral therapy. And I think a lot of providers also do encourage behavioral activation, even if you don't know the terminology. Behavioral activation is really helping patients gradually re-engage with their daily routines, um, physical activity, and into those meaningful activities, because this can actually just help shift mood and cognitive function significantly. So I often get asked, what's the difference between counseling and psychotherapy, since we're on the mood subject? And does it matter in concussion care? So counseling tends to be more supportive, informal, and short term, often provided by more generalist providers. It's often helpful for adjustment, grief, stress management, or just really providing a space to talk. Whereas psychotherapy, on the other hand, especially when delivered by a trained clinician, is more structured, evidence-based, and goal-oriented. It really is essential when a patient is experiencing clinically significant anxiety, depression, trauma, or functional somatic symptoms. Um, Cognitive behavioral therapy is probably the most well-supported approach for managing many psychological diagnoses, as well as persisting symptoms after concussion. CBT is a structured, evidence-based, time-limited psychotherapy, and it's based on several core principles. including that psychological issues are partly based on problematic or unhelpful patterns of thinking, that psychological issues are partly based on learned patterns of unhelpful behavior, and that psychological issues are partly based on problematic core beliefs, including central ideas about oneself and the world. So during CBT, a mental health professional, whether that's a psychologist or a master's level clinician, will help the patient take a closer look at their thoughts and emotions. And then the patient will come to understand how their thoughts affect their actions, unlearn negative thoughts and behaviors, and learn to adopt healthier thinking patterns and habits. Some of the key techniques used include relaxation, mindfulness, as well as behavioral activation that we just discussed. Um, So I like to apply kind of the CBT thoughts and how this in the context of persisting symptoms after concussion. The thought patterns often manifest something like this. And it's often a fear that one will not recover from their injury, which can trigger the cycle shown here. So, in the context of concussion, that cycle often looks like this. So, a symptom triggers catastrophic thoughts, such as, my brain is damaged, which then increases distress and arousal, such as that flight or fight response, which then leads to physical symptoms like headache or dizziness, which then reinforces the fear and drives further avoidance. So, CBT can break this cycle by working to challenge negative and harmful thoughts, encourage gradual return to activity, and reduce that autonomic arousal and improve sleep. So, back to our case, these are actually the findings from the MMPI. I gave her a personality assessment in clinic, and it was valid, just like her cognitive data. And really, her elevation showed it that she was having a lot of somatic complaints, particularly with head pain, and that she was more likely to present with multiple somatic complaints and more likely and prone to developing physical symptoms in response to her stress. It also, the elevation showed very significant emotional distress, symptoms of depression, as well as anxiety, um, and a lot of fears that would restrict her normal functioning. So for this case, I kind of broke it down into like, what are the factors here that were driving her persisting symptoms? She was a female. She had a history of ADHD. She had the history of migraine headaches. She had some sleep disturbance before. The motor vehicle collision, that context of that injury, those patients tend to take longer to recover than our sports related. Because in a sports, you're kind of almost, if you're playing football, you know that that is a risk associated with it. But not many of us, although we probably should in Louisville, think about the every day we get in the car. There is a risk of injury maybe. But she also had that early onset pain and headaches within that first 24 hours. And the biggest is these post-injury factors. Unfortunately, I don't think that she got great education early, and I think that that prolonged her symptoms. She did go to multiple medical providers before I saw her, and never was really given good information. She didn't have support. She lost her mom. There was a lot of grief and anxiety and depression. She had a significant delay in returning to school. She was still experiencing pain. And of course, the litigation that I see a lot of that driving persisting symptoms. So for diagnosis, I did not give her a diagnosis of post-concussion syndrome. I diagnosed each of the factors separately. I think that that really shows like what we're targeting here and what's the driving force. Um, And then my treatment recommendations. She had a lot. I wanted her, and that's actually, this is a very typical, I would say, like case is that I am referring to psychiatry. I want people to get in therapy. And I did refer her to the headache clinic there. I wanted her to get a vestibular evaluation to figure out if she was a candidate for vestibular rehab because of that dizziness, because she was working at a job where she was staring at a computer all day, and that was really disabling. I prescribed exercise as well as a referral to sleep medicine to rule out sleep apnea just because of the concern with her hypersomnolence. So lastly, just some key takeaways. Obviously, the new updated ACRM criteria, I think it's really important that we're all versed in that if you're seeing concussion. Um, the term post-concussion syndrome is outdated, and I really encourage you to think twice before using that. Most patients do recover fully within days to weeks. And if symptoms persist beyond, they often reflect biopsychosocial factors. Beliefs, expectations, and language profoundly influence symptom persistence and recovery outcomes. And effective treatment is available. These patients will and can get better. I have some resources here for you all, as well as, I don't know if you are aware, but early when I started here, myself and Misty Agnew put together a concussion and TBI handout. It is available through the resource library, and I'm happy to share it as well, but she is the manager in rehab services. Because often it's recommended that you give these patients also in the earlier stages, maybe in the emergency department or primary care, a paper copy of everything since they might not be feeling their best. All right, so sorry, I'm like right up at the time, but any questions or? Yes, absolutely. Yeah. Um, I think that there's still a lot of literature about, what like multiple mild TBIs. I do know that the more recent literature has showed that MTBI does appear to incur a higher risk of maybe developing dementia as you get older, but the literature is pretty limited still and not great. But it does take longer to recover if you've had more. Yes. Hmm. Hmm. What would so I think that if he was cleared by the athletic trainer and he was clear of all his symptoms, he probably could return. I think that there's more harm with not having children specifically not participate in in these sort of activities or sports related activities. Um, but I think that him returning, as long as he was symptom free, I don't think it would be. Mhm. Yes. Yeah. Mhm. Like lower risk. It, and I agree. I think that it's controversial. Yes. I it is controversial. Yeah. But you still. Yes, absolutely. Because of the. I mean, I certainly get a lot of patients. I don't see as many pediatric patients um, in clinic, but I do get a lot of questions um, about CTE and that nature, and just like high contact sports and repetitive head injuries and things like that. I actually completed a CE last week about kind of TBI, and it broke out like moderate to severe and mild TBI with regard to like risks of prolonged cognitive problems or incurring like neurocognitive or neurodegenerative diseases. And I think that the jury's still out a little bit and the research still needs to be explored more. But I think that, yeah, there's going to be some risk of of maybe um, increased risk of maybe a neurodegenerative condition with mild TBI, but I think it also depends on the severity as well as the number and absolutely. And then I know that there's a risk with children not participating in like team sports because of the fear of developing. That can also be kind of harmful too. Mhm. It is, and I think that we'll know that. I am in a little bit of a niche role where I have a bit more time than a lot of my physician colleagues. Um, I do think that it is hard to get buy-in, especially the longer, and I really think it starts with the initial point of contact. I wish we had our emergency like medicine providers here as well as our primary care providers, because I do agree. Like I think it's early. And a lot of times I feel like neurologists, PM&R are getting these patients way later. And that is where it gets so tricky. And sometimes it is that at this point they have like this. There are like of course that percentage that are so bought in and this is their identity. And I do think that it takes time and they are the most difficult. They are. And like that's why we have the service is like maybe we're not doing testing, but I'm able to sit and talk with them and really kind of get to the heart of what's going on. But there is always that patient multiple that are really difficult. And I think it's because you're seeing them so far out, right? Yeah. Yeah. Any other questions? All right. Thanks.